All right, it's going to be tough to keep your attention here for a few minutes, but I won't be long. And I'll try to really just share with you some pearls that I have picked up myself the last few years. So it will be, I hope, very clinically relevant and a lot of it very straightforward. So stay engaged with me for another few minutes and then we'll get into the lab. All right? Thank you. Here are my disclosures. It's important to let you know that some of the work that I will present in this talk was sponsored by Medtronic Research Support. And I added this photo after dinner last night. Linda begged me to, she says to me, you must have a picture of your kids in your talk. So I did that, not knowing that my wife was also going to walk in on the talk, and she's here, so, but perfect. All right, so I thought, how should I start this discussion? And I came across a quote from the movie Sideways, and it goes like this: I like how wine continues to evolve, because a bottle of wine is actually alive, and is constantly evolving and gaining complexity. And it really made me think about what this meeting is all about. You know, our second annual advanced lateral course. I think it's really about, lateral spine surgery continuing to evolve. And it's been a great experience for me being involved in that discussion. I just love that it seems like it's alive. It's constantly changing, even in my own practice. And every time I meet with others and do these meetings, I am just constantly changing what I do and what I think we should do. And it's just an exciting time. I'll share a few cases, and hopefully from the cases you will see some commonalities, maybe some things that were not done ideally. And really, again, the focus of this is complications. The first patient is a 68-year-old female with lower back pain as well as L4 radiculopathy. She had had a previous L4-5 laminectomy by a partner of mine from 3 or 4 years ago. And she'd also had physical therapy and epidural steroid injections. Neurologically, she was intact. Here is her preoperative MRI. You can see the sagittal. I guess the pointer is not going to work too well. How about the mouse? No? Okay, you can see on there at 4-5 the previous laminectomy defect, and that's apparent. You can also see a grade 2 spondylolisthesis there. And on diaxial, facet disease with subarticular and foraminal stenosis. Do we have another pointer, or is this the one that we've been using? This is it, no? It's actually a small room, and what I would do is, if you can see on this side, I'll just point a couple things here, because as far as complications go with OLIF, it's really this axial T2 MRI that's become so important in our preoperative planning. And we're really wanting to look at the aorta, which is already bifurcated here, and the left psoas, and that gap. And that's really the gap that we're using to perform an OLIF. And if one is going to run into problems with an OLIF, it is most likely to be, in my experience, something vascular early on, and it's usually due to poor patient selection, poor planning. So, I remember when I first started doing these, Rick would always say it's all about the veins, and I think, in many ways that's true. So pay very careful attention to that T2 axial MRI and to the vasculature relative to the psoas. There's several other things that start becoming apparent. You'll start looking at the amount of fat that's underneath the psoas, and oftentimes that will tell us how easily the psoas will mobilize versus how easily it may not. When there's a lot of osteophytosis, then the muscle often gets very stuck, and so posterior mobilization of that muscle to widen the gap between the aorta and the muscle can be more challenging. Not impossible, but certainly things that you want to pay attention to early on. Patient positioning. Another area where complications can arise, so it's worth at least a quick mention. The OLIF 2.5 and for OLIF 5.1, there are some exceptions when we do that procedure from the right side. But for OLIF 2.5, for the most part, it's a left-sided procedure. So patient's always going to be left side up. It's going to be on a flat table. No need to have a regular table and to break the table. A flat Jackson works fine. And we don't flex that knee, the left knee or the upside knee, as we often do with a transmuscular surgery, because here we're not planning on going through the muscle, and so we don't want to relax that muscle. We want to keep that muscle taut, displaced posteriorly, and we want to have a nice space in here to work. The more we flex that hip, we close that gap right where our incision is going to be, especially for a 5.1 case. Here's a quick video just showing some of those steps. We put a bump underneath between the rib cage and the hip on the right side. That's not to break the spine. It's really just to provide some support as we mallet instruments down. We make sure all the pressure points are padded. This is the way I like positioning the upper extremities. I tape directly onto the patient's skin. I don't use green towels or blue towels. And I do use navigation for these cases, so I like to have the upper extremities also have a very low profile. If I want to slide the O-arm up that way, I can. So I tend to tuck that arm with a pillow, and this arm board can be rotated up to 90 degrees north to really get it out of the way. So I showed you that just because, the little things that can go wrong in positioning, and oftentimes it's too late in the middle of the case to fix it. So this is access, and I think this is very critical. So you saw some of this in the lab. This I think was a 4-5 level. This is the external oblique, the fibers here of the external oblique running in that direction, and just finger dissection to split them. There are occasional veins that you will encounter as you split them. It's okay to apply cautery to those. They can be associated with nerves as well, so be careful with cauterizing the nerves because it would cause a pseudo hernia. Here's the internal oblique, I'm sorry. Okay, now you can see through those two the transversalis. And if you look at the drawing on the left there, we're just making our way through those three layers, those three muscular layers into the retroperitoneum. Okay, so there's the transversalis muscle. And one really doesn't have to use cautery to open the fascia of each of these muscles. Sometimes just a finger can do it, but and that's peritoneum that you're seeing through all three layers of the muscle wall now. That's the peritoneum. So sometimes the peritoneum is pretty stuck back there, and you'll see the finger being rotated and swept posterior laterally. Now there's a lot more retroperitoneal fat that's in view, and a sponge stick is being used to sweep the peritoneum forwards and to expose the psoas muscle. This is actually the psoas muscle right here that's being lifted up with the suction, and so the peritoneum is dissected all the way down the front of the psoas until that white knuckle of the disc space can be seen. All right, so that's the access in OLIF, and again, the talk is about complications, so I'm just doing all these tidbits of pieces where I think things can go wrong. this is definitely an area where things can go wrong. And I think if things go wrong, it would be typically, in my mind, because of not enough direct visualization. If one can get back there and see the peritoneum, peel it forwards, make sure that the ureter stays with it, find the psoas, not tamper with the nerves, don't leave any extra peritoneum on the psoas muscle, because that could be essentially leaving the ureter behind on the muscle. Then these are the ways that I think we really can minimize complications during the access. The orthogonal maneuver, I missed Rick's talk. I didn't get all of it, but I think you made some mention of the orthogonal maneuver. And the importance of this is because we are coming in obliquely with our incision and our initial trajectory, there is a risk that the instruments can get into the spinal canal or the contralateral neuroforamen. So it's very important that if some sort of maneuver is performed so that an oblique instrument becomes orthogonal to the spine and can traverse the spine in a direct lateral fashion and minimize that risk. So here is, on the left is basically an illustration of that, where the instrument comes in obliquely and then goes straight vertical. And I've got a short video as well here. There's a cob going down with navigation into the disc space. You can see on the sagittal here, and you can see the surgeon's hand being pushed posteriorly so that that instrument is vertical and gets across the disc space. And the contralateral annular release here is being performed with that cob. So a lot of the same things that we're used to with transmuscular surgery, just with a few nuances that I'm trying to point out. The other end plate, same thing. Cob goes in obliquely, then is going to be pushed more vertically, and the annulus can be released on that other side. I don't use neuromonitoring for my OLIFs. I do have EMG connected to the patient typically, but I use it for the pedicle screw stimulation. And theoretically it's there as a backup if I had a problem that I wanted to investigate something, but I have not had to do that. So patients are usually paralyzed pharmacologically. Okay, so for that first patient, let's go back here quickly to remind you, this was that grade 2 spondy. This is what we did. We did a 4-5. This was a 4-5 level with a lateral plate. And also unilateral pedicle screws done while the patient's in the lateral position. Excuse me. So actually from a time and efficiency standpoint, takes about a couple hours to do the surgery, but with the patient entirely in the lateral position and with anterior and posterior fixation, instrumentation. Final X-rays here, you can see some reduction of the spondy. Okay, next case is a 66-year-old former Marine presented with low back pain and neurogenic claudication for 18 months. He was unable to stand for 10 minutes or to walk 1 block, failed physical therapy, and epidurals, was neurologically intact. Here's his MRI. The real thing that jumped out here at me was his 3-4 pathology. You can see there's some end plate changes associated with his degenerative disease. The axial clearly shows some moderate spinal stenosis, and I think that really is the cause of his neurogenic claudication. One of the questions that went through my mind is what do I do about that L5S1 disc? It's not the best looking disc, but really his biggest problem was neurogenic claudication, and I gave thought to doing a laminectomy without a fusion, but a few things pointed me away from that. One was the amount of end plate disease he had at 3-4. Also, this is a patient with congenital spinal stenosis, short pedicles. In a lot of these patients, simple decompression sometimes does not quite cut it. It's hard to get that subarticular decompression in a lot of these patients with very short pedicles. So for him, I opted to do a 3-4 OLIF using indirect decompression only to treat his neurogenic claudication. and unilateral perk pedicle screws, and he did well. He's done really well so far. Third patient, a 56-year-old. Should I look at the... I don't want to neglect to look at this anatomy here. It's probably something you've seen a couple times today already. But the aorta, psoas, nice big gap. And that was one thing that this patient had. Very favorable anatomy on that T2 MRI for an OLIF. So keep on paying attention to that. 56-year-old former bodybuilder, low back pain, bilateral L4 radiculopathy. He was in a motor vehicle accident years ago, and he remembered hurting his back. Since that time, he suffered from chronic back pain. He had physical therapy, epidurals, nothing really worked, neurologically intact. Here, he had a CT myelogram. I think he had some retained stainless steel metal in his body, could not get an MRI. So he had a CT myelogram. You can see the 4-5 lytic spondy right here, the pars fracture. And no significant central stenosis, just resulting foraminal stenosis from the spondy. Again, I don't want to omit here the vasculature. It's not an MRI, but you can see the aorta is pretty midline there. And this gap is not the largest gap. And so it doesn't mean that we can't do an OLIF, but that's when one would want to plan to, once you get to the front of that psoas muscle, take a Kittner or something and just push it back and widen that gap. And it almost always is possible to do that. I have even applied bovie-cautery, which is not something I would recommend that you do, but I've become so comfortable with the structures there. I've done that to release any tendinous attachments to the bone to allow it to be mobilized. But just the Kittner usually gives you enough room to do it. He got unilateral perk pedicle screws, OLIF, and lateral plate as well. And that's what he looked like. This was a 60 millimeter length, and it really looks pretty short. I looked at the final AP and I thought, this doesn't really get very far. But there's huge osteophyte. All of this is just bird beaking here, osteophyte. And he had the same thing on this side, which allowed me to get very deep with the plate. So wish I had an 80 long for him, but 60 was the longest. This next one I think is a 4551, so I haven't shown you any of those yet. This is a 55-year-old male banker, progressive back pain for 3 years, very hard time sitting, which as a banker you can imagine would be pretty tough. He sits for about 30 minutes, then he has to get up and stretch his back. He also has a right L5 radiculopathy, failed physical therapy and epidurals, neurologically intact. Here's his MRI. You can see he's got loss of lumbar lordosis and 4551 degenerative disc disease. On the axials, no real significant stenosis, but the vasculature here is very important. So he's got, this level, there's an early bifurcation of the aorta, and the iliocaval confluence likewise is pretty low. So now we got to decide if you're going to do an OLIF on this, then it's not a problem, but just make sure that you know what you're getting into. In this case, we were able to create enough of a gap here to do that surgery, and I did come in lateral to the vessels on this one. You can see a bit of muscle creeping fat underneath that muscle, and that just allowed me to get the bulk of that muscle out of the way to do it. The 5-1 is much more favorable here because of the early split of the vessels. They're wide. You've got a very nice wide interval to come in and to do the 5-1 OLIF in between the bifurcations. So, he's probably not the perfect candidate for surgery. He's a patient with, black disc disease. I usually don't enjoy operating on those patients, but he's just had such a miserable life and certainly wanted to try. But from a vascular anatomy is a perfect candidate. For him, I opted to do 4-5 and 5-1 OLIFs. In the front, I just put a single screw in at the 5-1 level to keep it in place, and then I backed up everything with cortical screws and sacral alar screws. So we got some lordosis, not an immense amount of it, but certainly better than where he started. Okay, so a few quick considerations before we go to the lab. A lot of talk is made of the lliolumbar vein. And the lliolumbar vein comes off the common iliac, left common iliac vein. And then there are veins that drain from that point more superiorly. And one of them is actually the ascending lumbar vein. So if you look at, I guess, figure 1, the most on that, there are 3 different structures draining into that vein, the common iliac vein. The most superior one is that ascending lumbar vein. And it eventually has anastomoses with the segmental veins. So that runs all the way up and down the spine. The most attention, though, tends to come from the lliolumbar vein proper, not the ascending lumbar vein. And that can be either one branch or multiple branches that drain into the common left iliac vein. They are, in general, going to be an issue more at L5-S1. If one is trying to go lateral to the left common iliac vein and to mobilize it medially, then that lliolumbar vein will certainly be at risk because it comes off laterally. It can, in transitional anatomy, get closer up to the 4-5 disc space, not at the 4-5 disc space, but up to the mid-body of L5. And so that's another place where the lliolumbar vein is vulnerable. I personally did put a pin through an lliolumbar vein when I was pinning the 4-5 retractor in place. I put the pin in L5. And it was not a disaster. We took out the pin and immediately saw a bleeding hole in a small vein. Packed it with gel foam thrombin and waited for a while, and it did stop. But that's what it was. And since that time, I've talked with others, and we've all agreed that at 4-5, if you're going to pin in L4 and not in L5, especially in the case of transitional anatomy. So this is something that gets talked about a lot. It's definitely a concern, but I think as one gets more comfortable with where that comes off of the left common iliac vein and where it is and implications of it, it's not a problem to deal with it. It's just a matter of being prepared, having vascular clips, bipolar gel foam, and suture if you're comfortable doing that. Transitional anatomy, I talked about this before, but whenever things split early, they get closer to the left psoas muscle. It makes it harder to get lateral to those vessels, in between the vessels and the psoas. This is a quote-unquote L4-5 level that looks more like, it could be L5-S1. So just the stuff that you want to plan. The ureter. I often get asked about the ureter. Am I going to get it? The ureter is usually attached to the peritoneum. As we mobilize the peritoneum forward, the ureter is going to stay with the peritoneum, I would say almost always. The times when one may run into trouble are if you're just blindly putting your finger in there and just pulling the peritoneum and you're not able to see. I guess your fingers can theoretically separate the ureter from the peritoneum, and you can leave it back, against the psoas or somewhere across the disc space. But really, if you're able to look down in there, as I was showing in the lab today, and bring the peritoneum forward along with everything else that it seems like it belongs with it, that includes the ureter, this structure will come. You can see it here, that longitudinal tubular structure along the peritoneum. You'll see peristalsis, you'll know what it is. And seeing it is better than not seeing it in my mind, because you know exactly where it is. And so a lot of times if you take care to find it, you'll find it. Ensure that the psoas muscle is naked. When you're peeling back the peritoneum, sometimes you won't see naked muscle. You'll see, you can see through a very thin veil of peritoneum, and you think, oh, I'm good enough. I've done enough dissection. Really be careful to peel everything forward, that's that white stuff, until you see the psoas muscle completely naked. That, to me, is the surest way that you've taken everything that needs to go and you've left behind only the nerves and the psoas muscle. I think the ureter can be pinched in some cases when there's a thin layer left behind and it's all thinned out in that layer and you just don't know what you're doing. And so take everything that should go forwards and leave the psoas muscle, just a naked muscle back there. Sympathetic chain. I think this is the last one of the the things I wanted to touch. I'm trying to touch the things I get asked about. The sympathetic chain, so here is the psoas muscle back here. This is the disc space, and here is the sympathetic chain. So this is anterior, that's posterior. And it often runs that close to the psoas muscle, right anterior to the psoas muscle. It's a pretty beefy vein. Nerve, the sympathetic nerve. It's a pretty beefy structure, and when you see it for the first time, you probably wonder what it is. And that was exactly what happened with me until Hal Silcox said to me, "It's a sympathetic chain," and it made such an impression that I never forgot what it was, because it's pretty large. I never thought of that chain as a large structure. So you'll often see it. It's okay to see it, and it can be mobilized. In this case, what I was doing was to take the Kittner and to sweep it down anteriorly, and to create a bit more space here for me to work to do the OLIF. I'd rather sweep it down than back, because if you sweep it back posteriorly, when you make that turn, that orthogonal maneuver, you can stretch it even more, or you can cut through the chain. So better to bring it down, and usually just the Kittner does the trick. If you want to use METs to release any fine attachments, you certainly can. All right, so that's it for the pearls. This is just some data that we are submitting right now for publication. We took 150 consecutive patients. There were 13 patients that were eliminated because they did not have a minimum of 6 months follow-up. There were 73 females, 64 males. Most common indication for surgery was degenerative disc disease, followed by spinal stenosis, followed by disc herniation, followed by spondylolisthesis. This is what everybody's been asking. Is OLIF safe? And I think finally I've got some data that we are submitting for publication to answer that question. OLIF 2.5 by itself, there was a 7% rate of postoperative ileus. Rick and I have talked about this. We know that in our current practice, it's much lower than this, but this was when there's quite a lot of learning curve. We were doing things differently. And so if that's the worst thing that we've got to report, we're pretty proud about it, because we've definitely seen a significantly less incidence of ileus. For OLIF 5.1, we had I think 2 or 3 vascular injuries, all venous, and they were the things I mentioned before. They were related to lliolumbar vein, medial sacral vein, and left common iliac vein itself. And not to be defensive, but a lot of this work, Rick and Wassell were doing with a whole different set of retractors without lights, and the way that we're doing it now is much different. The third group here is OLIF 2.5 combined with OLIF 5.1. And nothing really there that jumped out. There was also some ileus, some vascular injury, 1 patient blood transfusion, 1 case of retrograde ejaculation, although from my careful review of the chart, it seemed like it was more of a psychological problem. And so really you add it all up, the 3 groups, the patients that had OLIF 2.5 by themselves, OLIF 5.1 by itself, and OLIF 2.5 combined with 5.1, the overall complication rate of OLIF that we've got in this series is 7.3%. How does that compare to other stuff? I'll show you in a bit. We also did a CT scan at 6 months on all of these patients, and independently had a radiologist review them for fusion rates. And the overall fusion rate was 94.9%. And you can see how it changes based on the group OLIF 2.5, OLIF 5.1, and combined. We looked at fusion rates based on the level. L1-2 had the lowest fusion rate, but you have to also appreciate that there was only one L1-2 level that did not fuse. The reason why the rate is so low is that those were the lowest number of levels, 13. So 1 of 13, giving us a fusion rate of 92.3. Others were all high, especially 5.1. Of note, that was 100% fusion rate. If we look at fusion rates based on the number of levels that were operated on, as we operated on more levels, the fusion rate slowly decreased, and we expect that. It's kind of like what we know from an ACDF. 1 level surgery is 100% fusion, 2 level surgery 98.3, 4 level 98.7, 5 level 96. But overall, the fusion rate is 97.9, and this is at 6 months. How does OLIF compare to our historical controls? If we compare OLIF first of all, we've got to compare OLIF 2.5 to LLIF, because that's what it's more like, to a transmuscular approach. And we've got to compare OLIF 5.1 to an ALIF, because that's what it's more like. So if we do that comparison, we said the overall OLIF complication rate was 7.3. The overall ALIF complication rate is 14.1. Overall XLIF complication rate in one series, 6.2. And in another series that looked at XLIF and DLIF, 22.4. So one thing to point out as well with the XLIF DLIF group is neurological injury as high as, in some of the series, 13.8 and 39.5%. And didn't have any of those at all in the OLIF 2.5, 5.1 or OLIF combined 2.5, 5.1 groups. So, this is just the beginning of a conversation, but I certainly wanted to share this with you. We've submitted this for publication, and I think we can definitively say that the risk of the complication rate of OLIF is satisfactory. It's equal to what we do right now with lateral surgery and with ALIF surgery, with certain potential benefits. Thanks for your attention. I'll certainly take questions. I know we're running late, but if there are any questions, I won't not want to pass the opportunity to reply.
Thanks very much.